Jason is another very amazing surgeon from Kerala, and whenever I've gone to the Kerala State Conference, I have been always truly impressed with the very casual way with which he'll come out with a string of his videos. And he's the senior consultant, Jyoti Eye Care Hospital, Palli Kannur. So on to you, Dr. Jason, and let's learn something more from you.
Good afternoon, madam. Am I audible?
Yes.
I'll share my screen. Is it visible?
Yes.
Today I'll be showing a few cases of DM detachment managed by desmetopexy with isoexpansile C3F8. So in this case, this is a hard cataract, you know. These are the predisposing factors: age, Fuchs dystrophy, pseudoexfoliation, prolonged surgical time, and blunt instrument. These are the predisposing factors for DM detachment. I don't know which has created DM detachment in this case. Probably I have injected viscoelastic between stroma and Descemet's membrane, and I had a tough time to wash off this viscoelastic in this space, so without creating further extension of the Descemet's membrane detachment. So so that visco is cleared, and I have used 14% isoexpansile C3F8. You are supposed to fill 2/3 of anterior chamber using this, and the site of entry is through the clear cornea, where DM is attached. And at the end of procedure, I'm supposed to place sutures. This is to prevent C3F8 loss, which can happen because of the secondary glaucoma, pupillary block glaucoma. This is the third post-op day picture, and this is the first week post-op picture, and this is the third week picture. You can see clear cornea using this technique. The second case is a spontaneous Descemet's membrane detachment. This happened after 3 weeks following an uncomplicated cataract surgery, and her vision dropped from 6/9 to hand movement. And this patient had a bilateral cornea guttata, and the surgery was uneventful. I have used heavy molecular weight viscoelastic also, and there was no chance of a surgical error in this case. And postoperatively for 2 weeks it was normal, and third week she developed this. So this case also I could attach good result I could get with the C3F8, isoexpansile C3F8, but unfortunately third week patient came up with this picture, and again it was taken up for reattachment using C3F8. Again, the same wound paracentesis was opened. I can see it is made in the clear cornea where there is no detachment, and C3F8 tamponade is done. And this time the technique is supplemented with internal fluid aspiration. The fluid between the stroma and the Descemet's membrane is aspirated using making a small incision, not exactly at the center, just below the center of the cornea, and the fluid is leaked through the wound. And this was the initial result was good. This was the second week picture, and you can see only a small area is detached now. But unfortunately, again, patient had a detachment, and this time I was forced to supplement with transcorneal sutures, including the Descemet's membrane. This OCT is after suture removal. You can see the suture track here. This is the 1 month post-op picture. Now you can see the corneal scar because of the corneal suturing. This is third case. This patient presented to us 4 months after cataract surgery, and because it was the surgery once done elsewhere, and DM detachment was not attended. And this case also, we tried injecting C3F8 and a transcorneal through and through suture, including the Descemet's membrane, was done. Uh, uh, this is how it is sutured. And I would like to share, this patient underwent otherwise surgery following when he came first instance itself. And that I also had Descemet's membrane detachment, but that I could manage with C3F8. But this eye was a failure, and patient is waiting for a DMEC procedure. The conclusion is decimetopexy is a useful technique. Sometimes you may have to combine it with sutures and internal fluid drainage. Thank you very much.
Thank you very much, Dr. JAISON, for the wonderful array of videos which you showed, which brought home your point. But I have a very basic question here, and I want my expert panel also to give their opinion. My thought is that an air is sufficient in majority of the situations, unless it's a very bad tear and you feel you need something, a longer non-expansile gas to be staying there and not an air bubble which might not stay that long. I would rather do with the whole thing in majority of the situations with an air bubble itself, and not think of using C3F8 gas. Keep it only for very bad DM detachments which need a longer time. The second thing is, how easily would you think of doing a venting? Because you could even have epithelial ingrowth and seeding and all that. So, but then if there is a viscoelastic in that interface, maybe then you would have to do it. But would venting be easily or commonly done at all? And of course, did that transcorneal suture actually keep the DM in place? Because by then, a few months, the DM area of DM detachment could get fibrous too. So does the opposition occur well in those situations? I have these questions to you, Dr. JAISON.
Madam, initial days I was using air only. I was not used to this C3F8. And very recently only I started using C3F8. I think results with C3F8 is much better compared to air. Air initially what I used to do was I will overfill the anterior chamber.
Yes.
And in 4 hours time I will again evaluate that patient. Probably that time patient would have developed papillary block glaucoma, and a control leakage of the air is done. Usually when the DM stays for 3-4 hours,
yes,
usually they stick on.
Yes.
They stick on. But with the C3F8, you don't have to overfill. And that is the advantage I found. You just have to fill the chamber 3/4, 2/3, I mean. And you ask the patient to lie down flat 3-4 hours every day. And this is doing wonders actually. You don't have to face the...
You do inferior PI in all your patients?
Actually, I recommend doing inferior PI. I've never done, but every time when you develop secondary glaucoma in these cases, I thought of doing a PI. So I recommend PI, inferior PI, when you get DM, when you're managing DM detachment, because you don't have to face the issue of secondary glaucoma. That will really block the development of secondary glaucoma.
Yes, Dr. Gaurav or Dr. Rohit, anything to add here?
Yeah. Since the time we got the AIOS, so that has really helped in visualizing everything. So that is something which can be a big boon in such situations. Dr. Gaurav has also ordered, if I'm not wrong. So he's also going to have an AIOS with that RT-VOID. So I have also, the question which you asked, the second part of the question was, in those, I have always used air for that matter. And I have not still ventured into using what Dr. JAISON is using. Yeah, absolutely. And all that I do is that I make the patient, you have to be very clear from where you have to go in.
Yes.
And then you have to inject air. You have to give patient Diamox post-operatively, make the patient lie supine. And, that mostly it does the work. But if required, you can repeat it after a few days. But in all my cases wherein I had the need to do it, I used only air in all my patients.
Yeah. And you should suture your wounds also.
Absolutely.
Yeah.
And there should not be, the air should be, should remain there. There should not be any leakage.
Yes.
Because that is going to create a situation wherein the membrane will again, find its way to get detached. So that is the most important thing.
As Dr. Jason has said, the 3-4 hours wait is quite enough for the DM to get attached. Yes.
Ma'am, I wanted to add a couple of things.
Yeah.
So basically, if it happens in the primary surgery, and if you have a small superior DMD, it's pretty easy to just, let it settle and put air, and it'll take care of it. But if you're dealing with a DMD which happens later, for example, it's been there for a couple of days, or in one of his cases where it happened subsequently, the chances are that, the air will not be sufficient to let it settle back, and you will get a recurrent DMD within a day or two. It might remain there for a day or two, and then it'll just happen again. So there C3F8 definitely becomes much more useful if it's a, like a older DMD, or if it's happening a second time and you need to intervene a second time. So C3F8 is very, very useful. And also if it's an inferior DMD, then they are much, much more challenging to deal with, because they tend to not settle down. And even if they settle on table, they will happen again. And rarely, we've actually had to do C3F8 2-3 times, and then also do the venting incisions and the suturing to manage this. And then these measures are required at times to deal with recurrent or inferior DMDs. I think, and sometimes if it starts from the side port, especially from the main port, most often it'll be usually a limited one, which is because of your instrumentation. Sometimes from the side port, if you're pushing fluid or viscoelastic, it creates a fluid wave and creates a big DMD. And there you have to be very careful, because if it's viscoelastic, whatever you might do, it will not settle down and it will just keep recurring. So to ensure that viscoelastic is removed from between the descemetes and the stroma, you have to make sure that it's washed out adequately as well.
And important thing is, sometimes the patient may have corneal edema and you may not have expected a DM detachment. So you could do just hypersol, or you could use a glycerol on the epithelium, and so that you get clarity, or even use an endo-illuminator if you or a transconjunctival illuminator, and locate the DMD, and then locate how you're going to go about what is the extent, and then plan how you're going to inject your air bubble from which side port. And as Gaurav had said, that the side port hydration can also be the final mission maker of creating a DM. So you need to ensure that your side port is hugging the stroma as you are hydrating and not entering the incision at that point of time. It is also very important that the eye is not too soft, hypotonic, or it's a shallow anterior chamber. Never use blunt cannula, blunt instruments, or even a loose sleeve of your phaco probe could actually tent up the DMs. So these are all some essential tips. And again, you take our port inside, phaco probe inside, and then start the infusion, because there might have been a small inadvertent DMD you've created. And if the infusion starts even before you have entered the AC, that could further unfurl the DM. So we need to be careful at every step of the surgery in the initial parts to avoid it. And if you have had it, then you could do a retroillumination and see it to locate the DM, and you could still do it. And of course, if you have the OCT, then it makes things a lot easier. So I think, yes.
Quick points, I mean, in the sense that I agree with Jason and Gaurav for most of the things they said. Yeah. We also, whenever we are faced with this situation, air suffices. But when it's a recurrent DMD, yes, then using C3F8 mix is a good idea. And just for the information of others, the way it's done is you take 0.2 cc of C3F8, and it's a 1:5 dilution that you do. Take 0.8 cc of air, and this is an ISO expansate. So if you don't do an overfill, the chances of it creating a very high intraocular pressure is somewhat limited. And at the same time, because the gas remains in the chamber for a longer time, it works quite in a better way than just filling it with air. One other factor that you need to keep in mind is when the surgery has gone off totally uneventfully, and the first post-operative day you find significant corneal edema, you are sometimes forced to differentiate it from a task situation where you can have absolutely white sclera, everything eye being quiet, but the significant corneal edema unfolds. If it's limited to a certain area, then in those cases it might be more of a DMD, but if it's a limbus to limbus, and then it becomes a little more difficult to differentiate. In these situations, maybe doing an anterior segment OCT will help, where the detachment of the DMD will become more obvious and it can be managed in the base it has been shown. Of course, I feel that the venting incision may not be necessary in most cases simply because the moment you do a good air fill or a C3F8 gas fill, that itself massages out the fluid between the descemet membrane and the rest of the stroma. And I'm quite intrigued by what Dr. JAISON said about 3 weeks later, a spontaneous detachment. I never faced this situation. I mean, is it being described?
Yes, it has been
Yes.
described as a late detachment which can occur. It was because initially the edges get fibrosed. So, it apparently stays okay. But anyway, some of these eyes are basically eyes with an endothelial disease.
What
Where
he says is that the cornea was looking good for 3 weeks and subsequently it developed that DMD. I mean, can you answer that, Dr. JAISON?
Sir, actually, that patient had Fuchs dystrophy, both eyes. And it was an uneventful surgery because Fuchs was identified before surgery. Actually, we have used heavy viscoelastics. And we didn't expect any issue. And patient had 6/9 vision for 2 weeks. And then suddenly developed a DM detachment. This is not my first case. I had another case which I couldn't record. That patient also had this kind of issue. That patient endothelium was quite okay actually. Patient developed DM detachment after 2 weeks. And second day when I operated, I took all measures. It was a very easy cataract, all measures. And I could do without DM getting detached. But that surgery was done during the within weeks after the first surgery. So I was managing the DM detachment in the first surgery. Since patient's vision was very poor, I was forced to operate the other eye. So I gave Diamox for the first eye for the secondary glaucoma. And because of when I started Diamox, second I developed some corneal folds. And I started feeling that it might get detached. And there was a small OCT. I could see the subclinical detachment in the second eye. But the moment I stopped Diamox, it got reattached. So I think there is, and the same patient developed recurrent corneal edema in the next year, and which was treated with micropuncture. So I think some patients has some basement membrane issue, which is creating this spontaneous detachment.
Thank you.